Welcome to this video conference coverage from the 2024 American Society of Clinical Oncology annual meeting in Chicago, Illinois, and the European Hematology Association Hybrid Congress in Madrid, Spain. In this series of 5 episodes, our expert hematologists, oncologists, Dr. Sairah Ahmed and Anne Lacasse will review the most recent data for the treatment of patients with non-Hodgkin's lymphoma, including diffuse large B-cell lymphoma, follicular lymphoma, mantle cell lymphoma, chronic lymphocytic leukemia, and an overview of the hot topics in the field. Stay tuned until the end of the program, where Dr. John Winters from New England Cancer Specialists joins us for a discussion about how these data may impact community hematology oncology practice.
Hi, I'm Dr. Anne Lacasse from Dana-Farber Cancer Institute. Today I'll be discussing data presented at ASCO and EHA for the treatment of CLL/SLL. Many of the resources we discuss during this program can be found on the Lymphoma Clinical Research Center at www.exchangecme.com. 2024 has been an exciting year with a new CAR T-cell approval for the treatment of CLL, following on the heels of pirtobrutinib being granted accelerated approval at the end of 2023. So on March 14th of this year, the FDA granted accelerated approval to lisocabtagene maraleucel for the treatment of adult patients with relapsed and refractory CLL/SLL who've previously received 2 or more prior lines of therapy, including a BTK inhibitor and a BCL2 inhibitor, based on response rate and duration of response from the phase 1/2 Transcend CLL 004 study. So in this study, this was an open-label study that included high-risk adult patients with deletion 17p, complex karyotype, and unmutated IGVH with a performance status of 0 or 1, who otherwise were healthy enough to participate. 137 patients were enrolled and underwent leukapheresis at 27 sites. And of that 137, 117 patients were treated with Liso-cel. In the primary efficacy analysis set at the second dose level, this included 49 patients. The rate of complete response or remission, including incomplete with marrow recovery, was statistically significant at 18%. In patients treated with Liso-cel, grade 3 cytokine release syndrome was reported in 9% of patients. There were no grade 4 or 5 events. And grade 3 neurologic events were reported in 18% of patients. One was grade 4. There were no grade 5 events. Among the 51 deaths on study, 43 occurred after Liso-cel infusion, of which 5 were due to treatment-emergent adverse events within 90 days of the Liso-cel infusion. One death was related to macrophage activation syndrome / hemophagocytic lymphohistiocytosis. So I think this data, is interesting, but this complete remission rate of 18%, I think, is quite low, and I think this is very different than CAR T in other subtypes of lymphoma, likely related to issues with the T-cell fitness in patients who have been very heavily pretreated. So I think this will be an option for some patients, but I do think we need more data to really assess whether CAR T should be part of our treatment algorithms routinely. And I think the deaths that were thought to be treatment emergent adverse events was relatively significant. So very exciting, but I think, again, we're going to need to see some more follow-up and really try to learn who are the patients who should be getting CAR T who have CLL. So let's discuss frontline therapy in patients with CLL/SLL. So although we're now using acalabrutinib and zanubrutinib in the US predominantly, ibrutinib was really a complete game changer in the field and was our first-in-class BTKI available. So we saw the 10-year follow-up of the phase 3 RESONATE study. This is the longest follow-up of a phase 3 study of any targeted agent in CLL, with a median progression-free survival of almost 9 years, 8.9 years, which was significantly longer with ibrutinib compared to chlorambucil at 1.3 years. And responses to ibrutinib were sustained over time. At 9 years, progression-free survival was 49.7% for ibrutinib and 4.4% for patients treated with chlorambucil. The 9-year overall survival rate was 68% for ibrutinib, whereas in the chlorambucil arm, the overall follow-up was discontinued after a median of 5 years. So really impressive long-term control of disease with ibrutinib. So there's a small ongoing phase 2 study at MD Anderson combining pirtobrutinib, venetoclax, and obinutuzumab. We've seen these triplet combinations studied in CLL. This is the first one with pirtobrutinib in frontline treatment. Is looking very promising. They looked at undetectable minimal residual disease at 10 to the minus 6 sensitivity. And at 12 months of combination therapy, 85% of patients were undetectable MRD at cycle 13 in the bone marrow. So impressive. So more to come with this combination. So we saw Arm D of the phase 3 Sequoia study, which looked at the combination of zanubrutinib plus venetoclax in patients previously untreated with high-risk CLL with deletion 17p or TP53 mutation, and we know this is a very high-risk population. The overall response rate was 100%, and the CR plus CRI rate was 45% in 65 response-evaluable patients. Undetectable MRD was approaching 50%. With a median follow-up of 32 months, the 12 and 24-month progression-free survival estimates look very good at 95 and 94% respectively. There is an ongoing phase 3 Celestial study in treatment-naive CLL evaluating zanubrutinib in combination with a next-generation BCL2 inhibitor, sonrotoclax, as fixed duration in patients with previously untreated CLL. So we saw a very interesting study from France. This is the phase 2 erratic study. The primary endpoint of this study was the percentage of patients who had undetectable MRD in the bone marrow at month 9. The month 9 data was presented. It will also be eventually updated to assess the month 27. So patients were treated with ibrutinib plus venetoclax for previously untreated CLL in a population of patients who had IGHV unmutated, deletion 11q, or complex karyotype. And at month 9, the bone marrow undetectable MRD rate was 38%. That was in the experimental arm. And in the standard arm with FCR, it was interestingly 69.4%. And I think this was quite interesting to see that standard chemoimmunotherapy resulted in faster achievement of undetectable MRD in this particular study. However, as you follow patients over time, the percentage of patients who became MRD undetectable increased between months 9 and 15 and became higher than what was seen in FCR. And we'll really look for the upcoming data analysis at month 27 to help us determine the best strategy, and this will be presented at subsequent meetings. The toxicity in both treatment arms was obviously an important parameter to consider when trying to figure out whether you would continue treatment or whether to stop if the MRD became undetectable. In the phase 2 Captivate study, frontline ibrutinib plus venetoclax, we saw ongoing impressive results at up to 5.5 years of follow-up in patients with CLL and high-risk genomic features, as well as in the overall population. The median progression-free survival has not yet been reached in the fixed duration cohort of patients receiving ibrutinib and venetoclax. And the achievement of undetectable MRD did correlate with progression-free survival, as we have seen in many other studies. In the patients with 17p deleted or mutated TP53, complex karyotype, and unmutated IGHV, again, we saw meaningful survival benefits from fixed duration combination of ibrutinib and venetoclax. This is probably more relevant where they are using this combination in Europe. In the US, we're not using ibrutinib as much, but this data continues to look very good with long follow-up. So now let's pivot and look at some of the studies in relapsed and refractory CLL. So the phase 1/2 Bruin study was evaluating pirtobrutinib, the non-covalent BTK inhibitor, which has a very favorable toxicity profile. And this demonstrated promising efficacy in patients who were relapsed and refractory to prior BTKI, and those patients who had not yet seen BTK inhibitors. The overall response rate in patients who were BTKI naive was nearly 89%, with 1 complete response and 30 partial responses. The overall response rate, including PR with lymphocytosis, was 91%, with 1 patient achieving a partial remission with lymphocytosis. So there are phase 3 clinical trials ongoing evaluating pirtobrutinib in BTKI naive patients, including in first-line setting in patients with CLL and SLL, and we look forward to seeing how these compare to the covalent BTKI data that we have seen thus far. So we talked a little bit about the Transcend CLL study, and drilling down on some of the exploratory analyses suggests that lower disease burden at baseline, looking at the sum of the products of the perpendicular diameters, beta-2 microglobulin, and the absence of bulky disease, and fewer lines of prior systemic therapy increase the likelihood of achieving a response with Liso-cel in patients with relapsed and refractory CLL. I think this is what we have seen in all of our CAR T-cell experience, that patients who have less disease and are less heavily pretreated do better. And I would say Liso-cel is modestly effective in treating patients with relapsed and refractory CLL, regardless of the presence of high-risk disease features, again with a complete remission rate of 18%. Higher baseline levels of inflammatory markers and renal insufficiency, in addition to high tumor burden, have also been associated with the increased risk of neurologic events. So finally, let's review studies that include both patients with CLL who are treatment naive and those who are relapsed and refractory. So there is an ongoing study, a phase 1b/2 study called the EPCORE CLL-1 study, evaluating epcoritamab in patients with Richter's transformation, which is remains a unmet need in the field of CLL. And I think we saw some really encouraging overall and complete response rates, particularly in the patients who had not been previously treated for their Richter syndrome. There are efforts ongoing to further mitigate the risk of CRS with optimizing the dose escalation strategies in cycle 1. Often these patients have very high burden disease, and the CRS can be a significant issue. We also saw the 7-year update of the fixed duration obinutuzumab, ibrutinib, and venetoclax study for primary treatment of patients first-line treatment of patients with CLL, and for the treatment of patients who had relapsed or refractory disease, with durable efficacy with a limited duration of therapy. This combination was given for just over a year. So the median progression-free survival was 88 months for patients who had not been treated, and 82 months for patients who are relapsed and refractory. Really very impressive data for this triplet combination in patients with CLL. So now that we've reviewed some of the important abstracts presented at ASCO and EHA, let's bring on Dr. John Winters, our community hematologist from New England Cancer Specialists, to see what he thinks about the data and how he may apply it to his patients in clinical practice.
Thank you, Anne. What a great review of recent data. I'm John Winters. I practice general hematology in the Portland, Maine area. And I do have a few questions. So pirtobrutinib is being evaluated as a first-line therapy. Do you foresee this being a good option for patients and just skipping the second-generation covalent BTKIs entirely?
So I think we're going to need some more data to really see, does pirtobrutinib lead to these really, we saw the data from Resonate with ibrutinib, really, really impressive long-term progression-free survival data. And I think we have to see, is pirtobrutinib as effective in the frontline setting, and what are the mechanisms of resistance, and can those patients who have had pirtobrutinib then go on to the covalent BTKIs and respond? It is a very well-tolerated drug. It does not appear to be associated with the cardiovascular effects like AFib. that we see, particularly with ibrutinib, but also some with acalabrutinib and zanubrutinib. It does have the platelet issue and the risk of bleeding, but otherwise is just a very well-tolerated drug. So I think we need some more data to really see how they're going to compare head-to-head.
Just another first-line therapy question. So, I think for years I've been seeing, we've all been seeing the BTKI plus BCL2 inhibitor combination plus or minus an anti-CD20. And all of those trials in general have looked very impressive, especially when you're looking at MRD. And I wonder, when do you think we'll see maturation of phase 3 trials and perhaps integration into guidelines, et cetera?
Yeah, it's a great question. And even now thinking about, we have data that acalabrutinib plus obinutuzumab has better progression-free survival than acalabrutinib alone, and we've been traditionally offering patients up front either a BTK inhibitor indefinitely or venetoclax plus obinutuzumab, and now thinking about these combinations. So I think we really need the comparative data to really understand, is there a survival benefit, or again, are we better off treating people with sequential therapies where, some of these patients are going for so many years on single agent therapy, and the cost of giving these combinations and the added toxicity. I think particularly with COVID and these other infectious things floating around, giving all three drugs together certainly does have some downsides. So yeah, it's a great question, and it's, when you have these patients on a BTK and BTK inhibitor for years and they're just cruising along doing great, it's interesting. I guess if you can do these time-limited regimens of triplets and really see these prolonged remissions, then maybe the financial concerns will sort of even out in the wash because they're not getting the long courses. So yeah, it's a great question. We've participated in some of these studies and really have seen some impressive data.
Do you see an endpoint not being just fixed duration or ongoing therapy, but maybe MRD as a clinical endpoint?
Yeah, I think so. It does seem to correlate with progression-free survival. I think it would be nice to know how that translates into an overall survival benefit. And, it's interesting. We do see these patients who are MRD undetectable 1 minute and then, their disease is progressing. So I think we still have a lot to learn about how to use MRD as an endpoint. But I think, if you have a 17p deleted patient getting ven plus obin, maybe the MRD is going to be really helpful in that setting to know. I have a patient right now who has had chemoimmunotherapy, was on a BTK inhibitor. He's now getting, he got ven-obin, and he's young, and I'm thinking, maybe I should be sending this guy for an allogeneic transplant evaluation because he needs many more years of life. So we decided to send MRD testing, and he was negative. So that made me feel kind of good about, well, maybe we can buy ourselves some time, and if he's starting to go positive, then we can jump to something else and then quickly refer him for allo. So I think it's going to help us with those kinds of decision making, thinking about what's next.
Yeah, it's interesting. I kind of have been sending, MRD and some of the younger patients, especially just because even though it's not in guideline and I'm not exactly sure how I might use it, I've been sort of liking, I like to kind of know. And so another question, Liso-cel just approved for treatment with relapsed refractory CLL who have previously received at least 2 prior lines of therapy, including a BTKI and a BCL2 inhibitor. Since this is the first CAR T product to be approved in this therapeutic area, how has it changed your approach to therapeutic decision making?
So I have to say, I want to see more data here. I'm not, it's not like with diffuse large B-cell lymphoma or mantle cell lymphoma where I think this is really a home run. And it's this patient population, like we were just talking about, in whom I'm thinking about referring for an allogeneic transplant. We have good things in the pipeline, but nothing that's going to result in a durable remission. And I'm just not sure Liso-cel is going to result in a durable remission. And, I think part of it is we are referring these patients who have so much disease. Some of them have, occult Richter's transformation, or they're just really, and their T cells, they've had so much therapy, their T cells don't work. So I think we need more data to really understand who are the patients who really might benefit from this. In our group, we have, I'm sure we will be sending some patients, but for some people it may be a bridge to allo, or if you have a patient who's just not an allo candidate and you're kind of running out of options, I think this is something that we would definitely consider.
Interesting. So it sounds like for a patient that's maybe out of options or running out of good options that is fit to do what you would like, you might reach for allo first, or only use CAR T in kind of a limited way at this point.
Yeah, I just, until we have longer term data, if the complete remission rate is 18%, and that's if you look at that data, a lot of patients never made it to their CAR T infusion. So if you did an intent to treat and really looked at how many people presented for Liso-cel, that number is even significantly lower. And so you're going to be treating a lot of patients for no benefit, and it's a very
pretty high cost,
huge cost. Yeah. And the toxicity, the treatment emergent adverse effect deaths were not insignificant. So I think we just have to be. I wish we had some other options, or maybe this therapy needs to be used a little sooner, or we've got to do something about maybe allo CAR T cells, where the T cells are actually of better quality, maybe something that will end up being effective in CLL.
Do you think BITE will be a similar story?
Yeah, it's a great question. I suspect it may be more of an issue than with DLBCL. But I hope, I'm sure we're going to start to see some studies because they're ultimately very combinable with other agents. It's nice to see, we have a study also in Richter's, which is such a problem. So it's nice to see that those patients do seem to be responding, and their T cells are presumably not so hot. So it may be at what, it would be really nice if we could figure out not only what's the T cell number, but are these exhausted T cells, or are these T cells that can really do what we need them to do?
Great, thanks.
Well, John, thanks so much for joining me today and for your great questions, and I'd like to thank our learners.
Thank you so much for having me.
Please remember to take the post-test and fill out the CME evaluation. Please watch the other ASCO EHA conference coverage videos where I discuss the latest data for the treatment of mantle cell lymphoma and hot topics in other subtypes of non-Hodgkin lymphoma. And my colleague, Dr. Ahmed, reviews treatments of diffuse large B-cell lymphoma and follicular lymphoma. For additional CME opportunities, clinical resources, and links to patient education materials, please visit us at www.exchangecme.com.